Hello, everyone from the Latin American region. I'm really happy to be here today to be able to provide this presentation. My name is Dr. Robert Bilkovski. I am going to be your lecturer today, and we're going to be talking about the topic of end-tidal oximetry. Let me just switch over into presentation mode, and we will be able to begin. So, like I said, principles of end-tidal oximetry, which is a little different. Most people are more familiar with end-tidal CO2, but this is going to be the topic of end-tidal oximetry, where there is some growing evidence that helps to identify potential therapeutic areas where this technology may have some benefits. The topic outline is as follows. First, we'll provide a foundation with regards to oxygen exchange and oxygen delivery. And then we'll focus in on some research topics, really focusing on two areas, the assessment of ventilation, and then secondarily, the assessment of pulmonary embolism. And then lastly, we will open up the presentation for a Q&A. So let's move on into the first part, which is more foundational. We'll be focusing on the physiology, oxygen exchange, and oxygen delivery. So if you want to break down oxygen exchange, it needs to be broken down into the most basic unit to understand the principle across the entire lung. And the easiest way to do that is to describe the alveolar unit. The graphic to your right provides a visualization of the alveolar unit where you have the ability to identify the inflow and outflow of both oxygen and CO2. And as it traverses across the capillary, coming from the pulmonary artery, undergoing oxygen exchange within the alveolar unit, and then through the pulmonary vein to return back to the heart for circulation. So simply stated, oxygen flows from the alveolus into the capillary, and in the opposite movement, CO2 will move from the capillary into the alveolus. Very foundational. Interestingly enough, the diffusion capabilities between oxygen and CO2 are different. CO2 diffuses quite rapidly, while oxygen is more gradual. Therefore, if you're remembering the graphic on the previous slide, CO2 equilibration occurs earlier, or to that bottom left area of the alveolar unit, while oxygen diffusion occurs more gradually. And the information to your right gives you a sense that a partial pressure difference of 5 millimeters of CO2 will result in a similar amount of equilibration or gas transfer as that of oxygen with a partial pressure difference in excess of 60 millimeters. So that gives you a sense of how big the differences in terms of diffusion capabilities between these two gases. Moving along to oxygen delivery. So once we leave the alveolar unit, the capillary leaving the alveolar unit coalesces into the pulmonary vein and then delivers into the heart. Oxygenated blood will then get distributed, and it gets distributed through the aorta. And at the 3 o'clock position, you will see the arterial oxygen content, also known as SaO2. The easiest way to evaluate that clinically is either from our arterial blood gas or non-invasively through SpO2, which serves as a strong correlate of that same measure. As the blood travels down and gets delivered to the tissue bed, oxygen will get extracted. The delivery of oxygen to the tissue bed is quantified as oxygen delivery, and it's a simple calculation of the cardiac output as well as the arterial oxygen content. And then now at the 6 o'clock position, as oxygen is being diffused across the capillary and being consumed, there is a certain level of extraction ratio and there is a certain level of consumption. And there's a relationship between oxygen extraction ratio, the oxygen delivery, and oxygen consumption. Once the blood is now returning back as venous circulation back to the heart to repeat this entire process, you will have SVO2, which is the venous surrogate of SaO2. And that is another means to be able to measure the adequacy of oxygen delivery and oxygen consumption. But boiling it down into its simplest terms, there needs to be a balance between the delivery of oxygen and then the flip side is matching that with regards to the consumption of oxygen, or DO2 and VO2 balance. Moving into some research topics, so that is the foundational principles of oxygen delivery and oxygen exchange. Let's go into the discussion on ventilation assessment. So current practices in the emergency department, in the operating room, and other acute care environments will rely on pulse oximetry and end tidal CO2 to be able to perform ventilation assessments. Both are non-invasive and both are continuous, which is advantageous for the ambulatory population. It is important to understand that under the conditions where hypoventilation are occurring, it is understood that there will be changes in SpO2 and end tidal CO2. Namely, as ventilation decreases, ultimately there will be a decreased change in SpO2, where SpO2 will drop below 90% and can be quite profoundly lower than that. In addition to that, the CO2 will gradually climb as hypoventilation continues. Interestingly enough, and you'll understand that in a couple of slides, that these measures are not as sensitive or time sensitive compared to utility of end tidal oximetry. So Linko and Palomeo have done some fundamental research several years ago now on the topic of ventilation assessment. To start off on the left with regards to hypoventilation, in individuals that had their minute ventilation reduced, you understand that the amount of gas exchange that is occurring at the alveolar unit is decreased. So therefore, the total oxygen that enters and the total CO2 that leaves the alveolar unit are negatively affected, or they're decreased. What will occur if you are measuring end tidal oxygen, and that's what the Linko study did, they measured end tidal oxygen and noticed that it decreased as minute ventilation was reduced. Similarly, as we talked on a previous slide, the end tidal CO2 increased. There is a note of the oxygen gradient here showing that it's increased. Just simply, we'll focus on the oxygen gradient in a little bit more detail, but at a high level, understanding that the oxygen gradient is a simple calculation, is the difference between the FiO2 and that of the end tidal O2. So as FiO2 is fixed, end tidal O2 changes up or down. The difference between those two can be a clinically informative value, with one caveat. Typically, the studies have been done with Linko and others that the oxygen gradient is most robust when the FiO2 is 60% or less. So if you're on 100% oxygen, it becomes unreliable, as an example. So flipping the gears to hyperventilation, the same thing in the opposite will occur. Minute ventilation means hyperventilation occurs and minute ventilation is increased. So that positively affects the gas exchange at the alveolar unit, which means that the total amount of oxygen entering and the total amount of CO2 leaving have both increased. Therefore, that would manifest as the end tidal oxygen has increased. End tidal CO2 naturally would decrease. And on the flip side, the oxygen gradient now has decreased. So these measurements, the end tidal oxygen as well as the oxygen gradient, can be informative to identify people that are going through bouts of hyper or hypoventilation. We talked about the oxygen gradient again, and interestingly, the follow-on study that was done by Linko in humans looked at the changes in the oxygen gradient compared to changes in end tidal CO2 and changes in SpO2 during periods of both hypoventilation and hyperventilation. And interestingly enough, that the oxygen gradient changed faster. So it was a much more early predictor, or not predictor, an earlier signal that changes in minute ventilation are occurring where the next one that is to change and to inform the clinician would be end-tidal CO2. And the last one, not surprising, would be the SpO2. So therefore, under periods of hypoventilation, the oxygen gradient would increase. And then the flip side, as I said on the previous slide, during periods of hyperventilation, the oxygen gradient would decrease. So clearly, one could surmise, is there opportunity to use this as a monitoring tool of patients possibly undergoing weaning? Could it be used for impending respiratory compromise? You know, we're all concerned about coronavirus at present time affecting oxygen exchange. So is there potential that the oxygen gradient can help to risk stratify these patients, whether they're weaning or they're COVID positive, and wondering whether or not they may need a higher level of oxygen support in the future? Just questions that can be asked now and answered in the future. So with regards to the change in the direction, so the change in end-tidal oxygen were found to be quicker than end-tidal CO2, as I said before, so that the oxygen gradient was summarized or concluded that it is a more sensitive indicator of hypoventilation than either end-tidal CO2 and SpO2. So potential applications. Now, there hasn't been any research on this, but people that had impending respiratory issues, being able to monitor the oxygen gradient, provided that they're not on high levels of FiO2, can be potentially advantageous to further risk stratify these patients. Second topic is with regard to the pulmonary embolism, and I think that there's been a little bit more evidence in here that shows that the end-tidal oxygen can be useful as a supportive diagnostic tool, and let's get into that in a few minutes. So first off, the end-tidal oximetry picture is really boiled down once again to the alveolar unit under pulmonary embolism. Here, the graphic representation on the right is focusing on two alveolar units where one has a shunt present. So therefore, that alveolar unit is not contributing to oxygen or CO2 exchange. So therefore, there is a retention of oxygen within the alveolus, and there is a relative decrease representation of CO2 in the alveolus as well. One of the most common conditions that causes a shunt is pulmonary embolism. There are others, but pulmonary embolism is certainly something that is front and center of people when they're concerned of chest pain and they may be short of breath. What you see with the graphic to the right is in the presence of a shunt, what can happen is that the changes in the end-tidal oxygen will increase. Oxygen exchange has been negatively affected, so a small amount of oxygen remains in the alveolus, and depending on the amount of shunt, the magnitude of change to the end-tidal oxygen can be quite large. In contrast, the end-tidal CO2 will decrease. So therefore, there are some utility from a foundational standpoint that end-tidal oximetry and end-tidal CO2 have some benefit in pulmonary embolism. So as I said before, but just to reiterate, so in the presence of a pulmonary embolism or a suspected pulmonary embolism, there will be an increase in the end-tidal oxygen while there will be a decrease in the end-tidal CO2. One of the questions that was posed by Paoletti is there any relevance of a ratio between the end-tidal CO2 and the end-tidal oxygen? And we'll talk about that in a sec. Interestingly enough, Klein, now back in 2006 at Carolinas Medical Center, actually did a study on this, looked at various respiratory parameters in patients that were suspected of having pulmonary embolisms. Interestingly enough, the lines highlighted in yellow in the bottom are showing that the end-tidal CO2 to end-tidal O2 ratios or fractions, there was a statistically significant difference between those patients that had a pulmonary embolism versus those that did not have a pulmonary embolism. Interestingly enough, in each of these scenarios, period 1, period 2, period 3 are representing episodes of tidal breathing. That means tidal breathing that is being measured over a 30-second period. The ratios, if you notice, are relatively consistent across them, but there is a break. In patients with a pulmonary embolism, that ratio of PCO2 to PO2 is less, while those patients that have a PE, that do not have a PE, have a ratio that is higher. And there was test sensitivities for a cutoff of 0.4, and that sensitivity for a pulmonary embolism was identified to be greater than 95%. And interestingly, receiver operator characteristic curves were also plotted for this ratio, and they're quite strong at 0.88. Interestingly enough, there hasn't been any follow-on articles in this regard, but the art of pulmonary embolism still requires the understanding of pretest probability. And this research helps to illustrate that this can be added into the medical decision-making for suspecting pulmonary embolism in the appropriate patient population. And on that note, I'll highlight the references that were used, LINCO 2 studies and the one by Jeff Klein, once again from the United States and California. And on that note, I will conclude the presentation. I appreciate the interest and attention, and I look forward to answering any of your questions. Thank you.